Welcome back. Please make your way back into the auditorium for this very important 2024 Karl Storz lecture. I am delighted to welcome Dr. Andrea Macneill as our Karl Storz 2024 lecturer. Dr. Macneill is a surgical oncologist at Vancouver General Hospital and BC Centre, and she's a clinical associate professor at the University of British Columbia, where she specializes in sarcoma and peritoneal malignancies. Dr. Macneill received her MD from the University of Toronto, where she also completed her general surgery residency and surgical oncology fellowship. She also received an MSc in environmental change and management from the University of Oxford. Dr. Macneill is a leader in the area of sustainable healthcare. She is a founder and principal investigator of the UBC Planetary Healthcare Lab, a novel interdisciplinary research collaborative dedicated to creating health systems that promote both human and planetary health. As the medical director of planetary health for Vancouver Coastal Health, she's working on a transformational planetary health strategy for the Health Authority to mitigate the healthcare climate footprint while creating health and social value. She's an executive member of Cascades, a pan-Canadian knowledge mobilization network dedicated to accelerating the transition to low-carbon sustainable healthcare systems in Canada. She is currently co-chairing a UBC Yale-led Lancet Commission on Sustainable Healthcare, where she oversees 4 working groups of more than 50 scholars. Her pioneering work in this area has been recognized with a large number of awards and honors, including the Canadian Association of General Surgeons Innovator Award and the Jmalhar Johnson Young Investigator Award from the UBC Department of Surgery. Dr. Macneill, thank you for joining us. We have so much to learn from you.
Thank you, Dr. Silla. And thank you to the SAGES Board of Governors and the program co-chairs, Mary-Lise, Caitlin, and Eric, for inviting me to share this message with you today. Thank you for your vision in recognizing sustainability as a topic worthy of this podium. I'm impressed there are so many people here just hours after the new Taylor Swift album dropped. Or maybe I'm just impressed that I'm here. Thank you all for the honor of your attention. I was a first-year resident in 2007 when I had my road to Damascus moment. Among the other pressures of adjusting to residency, I found myself appalled and grieved by the amount of waste we generated in the OR. Like the way that an IND of a perianal abscess that we would sometimes do in a merge with virtually no waste could fill 4 garbage bags in the OR. I undertook some self-directed research and discovered that in the not-so-distant past, hospital incinerators were a leading source of environmental dioxins, which are one of the most potent carcinogens known. And I realized that in the process of cutting out one person's cancer, we were creating conditions potentially leading to innumerable more. And I decided that that was a status quo I wasn't willing to accept. Thankfully, hospital incinerators are an historical artifact now, but dioxins persist as one of a multitude of environmental pollutants linked to ill health, be it cancer, cardiovascular or respiratory disease, or infertility. In fact, pollution is estimated to be responsible for 9 million premature deaths annually, or 16% of all mortality. The WHO has identified it as one of 5 major risk factors for non-communicable diseases, along with smoking, unhealthy diets, physical inactivity, and harmful use of alcohol. While we may not be able to make a causal association for the individuals we treat, I can assure you that we are treating the consequences of our polluted world every day. The current poster child pollutants are greenhouse gases, which are driving the climate crisis. Climate change tends to get more airtime than the related and concomitant ecological and biodiversity crises, so we'll concentrate primarily on the climate impacts of healthcare today. We have just lived through the warmest year on record, with average global temperatures surpassing the worst-case scenario models and prompting increasing alarm from the scientific community. This increasing climate instability is fueling all kinds of catastrophes that threaten lives and livelihoods and undermine the basic determinants of health. Last year's wildfire season shattered previous records. burning more than double the amount of land burned in any prior season, and blanketing vast swaths of eastern Canada and the US, and at times even Europe, in smoke, such that for a brief while, New York City laid claim to the world's worst air quality. This expose from the New York Times quotes an historian who called the 2023 wildfire season mythology becoming ecology, a slow-motion Ragnarok. The acute impacts of the fires are well documented in terms of emergency department visits for respiratory conditions, but the longer-term effects are only just beginning to be elucidated. This 2022 Lancet study reported on cohort data over the preceding 20 years and suggested higher rates of lung and brain cancers amongst those repeatedly exposed to wildfire smoke. I was in California in January when the Pineapple Express hit, which, to be clear, is a meteorological phenomenon and not Seth Rogen's favorite pastime. LA received more than half its annual rainfall in 5 days. A state of emergency was declared for 8 counties. At least 45 homes were destroyed in mudslides, and at least 9 fatalities were directly attributable to the storm. Now, I cite these examples specifically to convey that this is not a future problem. This is a now problem. Sustainability is not something you should care about for the sake of your children or your grandchildren, but for you and for us, and especially for those who are being disproportionately and unjustly impacted by it. High-income countries like Canada and the US have developed our affluent economies by emitting far more than our fair share of the world's carbon budget. And yet, it is vulnerable communities and countries who are suffering the worst consequences of climate change. In this respect, climate change can be considered the latest iteration of colonialism. We've now colonized the atmosphere. Health systems must adapt to this increasing global burden of disease due to our polluted and warming world, and at the same time address our own vulnerability to climate risks. Our buildings are subject to fires and floods, our supply chains are being disrupted, and our workforce is threatened. We had an awakening to this in British Columbia 2 years ago when the Pacific Northwest heat dome overwhelmed our emergency services and shut down elective surgeries. And shortly thereafter, wildfires necessitated evacuations of hospitals and long-term care facilities, and then an atmospheric river event washed away critical infrastructure, impeding access to health services. These events highlighted the need for adaptation, which means preparing for the inevitable effects of climate change and building resilience into our systems of care delivery so that we can better weather these storms. And this is one of 2 dominant pillars of climate action, the other being mitigation, which refers to actually decreasing our greenhouse gases to avoid the worst scenarios of dangerous climate change. Mitigation of health sector emissions recognizes that the relationships between health, healthcare, and climate are bidirectional, that our current model of care contributes to destruction of the ecosystems that underpin health, committing us to a vicious cycle. Globally, healthcare contributes 5% of greenhouse gas emissions, which is on par with the aviation industry. So decarbonizing healthcare would be functionally equivalent to eliminating air travel. The US healthcare system is responsible for a shocking 10% of national emissions. My colleagues Jody Sherman and Matt Eckelman published this seminal study estimating that pollution from the US healthcare industry is responsible for over 600,000 disability-adjusted life years lost annually, putting it on par with medical error. They conclude that this is a patient safety issue and healthcare sustainability should be incorporated into quality improvement initiatives. We replicated that study in the Canadian context and found that we're more on par with global average at 4.6% of national emissions, but nonetheless, we inflict a considerable amount of public health damages in our efforts to restore people to health. The field of planetary health has arisen in the past decade to capture this intersection of human and environmental health, to acknowledge that healthy ecosystems are the bedrock of civilization and human flourishing, and to work to protect both. If we apply those concepts to healthcare delivery, we arrive at what I've termed planetary healthcare. And I would suggest this begins with an expanded notion of our duty of care, from the individual patient to the rest of the population, present and future, and to the planet. And this concept is beautifully encapsulated in this Lancet call for an updated Hippocratic oath for the Anthropocene, which explicitly acknowledges our duty of care to nature. So how do we get there? We've published a framework for planetary health care to really convey the scope and scale of systemic transformation required. And we'll go through this in some detail, and I'll give you some concrete examples of work we've done in each of these domains. Now, the first thing to notice is that the framework includes both supply and demand side management, because we can't achieve net zero healthcare emissions with efficiency gains alone. In high-income systems, we need an absolute reduction in the demand for health services, and that can only be accomplished with healthier populations. But healthcare only modifies about 20% of health and well-being. The rest is the result of broader social determinants. Obesity, for example, is a complex, multifactorial problem derived in part from how we structure and operate our societies. This means that healthy public policies designed to address the environmental and socioeconomic drivers of obesity will be more impactful on a population level than widespread access to bariatric surgery. For example, urban planning that promotes active transport is associated with lower rates of obesity, diabetes, and related metabolic illness. Healthy food systems that enable access to affordable, nutritious food and address food insecurity can similarly lower the demand for obesity-related health services. But how does this relate to our environmental footprint? Well, it's important to understand that all healthcare activities consume material and energy resources and generate waste. So anything that reduces the incidence or severity of disease, consequently lessening the amount or intensity of care required, will decrease the healthcare footprint. In addition to optimizing the social determinants, this includes ensuring universal access to preventive services and good chronic disease management, to shift patient interactions with the system from the very resource-intensive acute care environment to the more low-tech, high-touch community setting. We sometimes refer to this as left-shifting patients up the continuum of care. For example, it is far less resource and carbon intensive to endoscopically remove a polyp than to deliver multimodal treatment for colon cancer. And we can further left shift care by modifying cancer risk factors like smoking or by optimizing HPV vaccination rates. The second operating principle of planetary healthcare is matching the supply of health services to demand. And I know that sounds a bit opaque, but we see supply-demand mismatches all the time. These are scenarios like patients using the emergency department for minor ailments because they don't have a family doctor, or patients languishing in acute care beds for want of long-term care or rehab facilities. Matching supply to demand means avoiding both underuse and overuse of health services. Underuse of necessary health services leaves patients vulnerable to avoidable disease. Most recently, underuse of COVID vaccines has resulted in patients in the ICU. Whereas overuse of health services results in avoidable harms to patients, financial harms to systems, and environmental harms. Inappropriate, or what's sometimes called low-value care, is care in which the risks or harms outweigh the benefits, or care that will not influence clinical decision-making or change outcomes. Globally, about 25% of health services are low value, and in the US alone, this carries an annual price tag of $100 billion. Appropriateness of care is an emerging dimension of quality, and it stems from both system structures, like how we structure and fund our system, and from clinician and patient behaviors. So I'll illustrate this with a study we did looking at a behavioral driver, which is specifically the physician tendency to order routine daily labs in an inpatient population. This is work done by two general surgery residents at the University of British Columbia, Drs. Annie Lalonde and Karina Spoialo. They recognized that unnecessary blood work has costs to patients in that they're awakened at 4 a.m., stabbed and drained of blood. It has costs to the hospital, and it consumes resources and generates waste. These three considerations comprise the classical notion of a triple bottom line. Annie and Karina led a consensus process within the Division of General Surgery to determine appropriate use of laboratory investigations in a number of uncomplicated acute care surgical conditions. And these resulted in recommendations like omission of routine post-op blood work after uncomplicated APIs and choles. They then compared these consensus recommendations to actual practice and found that 76% of our patients underwent unnecessary blood work. Each patient in these uncomplicated populations underwent a mean of 1.8 excess phlebotomies and lost 4.4 vials of blood. The cost of this unnecessary care to the hospital was $10,000 for 300 patients, and the carbon costs were equivalent to burning 61 kilograms of coal. This is one of a very few studies that rigorously reports on the entire triple bottom line to convey an accurate accounting of costs of care. We've published carbon costs for 20 common lab tests along with the associated consumables for the blood draw, in case anyone is interested in undertaking a similar quality improvement initiative and wants to calculate their impact. Avoiding unnecessary tests like routine blood work or unnecessary pre-op ECGs and imaging is a planetary healthcare action that is available to all of us as surgeons. This Canadian report documented up to 35% of low-risk surgical patients undergoing unnecessary tests, and a US study showed that up to 53% of healthy, low-risk patients are subjected to unnecessary testing. We are gatekeepers to considerable environmental resources in determining who has surgery, and we must always be mindful to consider non-operative management as appropriate. Now, I'm not a bariatric surgeon, but I can appreciate that this landscape is undergoing a dramatic shift with the widespread uptake of GLP-1 receptor agonists, and that the indications for surgery may be evolving as a result. Finally, we have to be responsible in our selection of surgical approach. I did a thorough lit review this week and found no evidence of improved outcomes with robotic cholecystectomy. In fact, a systematic review published 4 months ago suggests significantly higher common bile duct injuries with robotics, and yet they continue. The third operating principle of planetary healthcare is reducing emissions from the delivery of health services. And this is where we find the classical notions of sustainable healthcare, like green buildings, energy management, and electric vehicle fleets. But it also includes opportunities to deliver care differently, and this is where we as clinicians have a unique role to play. In 2017, we published this comprehensive study of operating room carbon footprints across 3 tertiary care hospitals, one in Canada, one in the US, and one in the UK. And one of the most striking findings was the contribution of anesthesia to the OR footprint and the opportunities to mitigate this. Now, this is a well-known story in the sustainable healthcare world, and many of you may be familiar with the fact that inhaled anesthetics are potent greenhouse gases, with global warming potentials ranging from 130 to over 2,500 times that of CO2. We showed a 10-fold difference in anesthetic emissions based solely on differential use of desflurane. At the time of this study, desflurane was the preferred agent at the North American hospitals, whereas the UK hospital didn't even have it on their formulary because of cost. One of my anesthesia colleagues in British Columbia took it upon himself to educate our local anesthetic community about this, and he published this paper in 2018 showing a 67% reduction in anesthetic emissions across 7 hospitals in 5 years, with voluntary shifting away from the use of desflurane and with the use of low-flow techniques. Increasingly, hospitals are restricting or eliminating desflurane use as a result of its outsized climate impact and the fact that it's more expensive with no clear clinical benefit. Even better than avoiding desflurane is avoiding inhaled agents altogether. This is work that my colleague Jody Sherman and her group have done at Yale, comparing different anesthetic strategies. And you can readily appreciate that anesthetics that include inhaled agents, which are shown in the top 2 bars, have significantly higher climate impacts than techniques like total intravenous anesthesia, spinal anesthesia, or peripheral nerve blocks. It's always nice to blame anesthesia for our problems, but we will now turn to what we as surgeons can do. And in some ways, the scope of our opportunity is even bigger because it gets to the problem of our supply chains. Recent greenhouse gas emissions inventories have estimated that 60 to 80% of healthcare emissions arise from our supply chains. And this is largely due to the dominance of single-use disposables in high-income settings. I was right to be aggrieved by the visible waste in the OR when I was a resident, but not for the reasons I thought. We tend to get quite focused on waste management, when in actual fact, it's the repetitive production of single-use disposables that's problematic. Up to 90% of a product's emissions arise upstream of its use, primarily from the extraction of raw materials and the manufacturing processes, whereas the way it's disposed of at end of life contributes relatively little. Single-use disposables are an example of a linear economy, in which products are manufactured, used once, and then discarded. This is an inherently unsustainable model, as it presumes infinite natural resources to extract and infinite regenerative capacity of the earth to metabolize the waste products. The alternative is a circular economy, in which products are maintained within the system through cycles of reuse, repurposing, repair, and remanufacturing, and then eventual recycling to recover the value of the base materials at end of life. This is a hierarchy of cycles, with reuse being the best strategy, because the product doesn't fundamentally change, and typically it requires minimal inputs to reuse. This is like doing your laundry so you can wear your clothes again, instead of buying a new outfit every time and then throwing it away after one wearing, which is essentially what we do in the OR. Notice that despite the universal enthusiasm for recycling, it is the lowest value strategy. And that's because it only obviates the need for the raw material extraction. It still requires considerable inputs of resources and energy to melt down or deconstruct a product and make it into something else. I was interviewed for a story that ran in the New York Times a few weeks ago, and after a lengthy conversation, the quote they chose to include was, "We will never recycle our way to a healthy planet." So let's take one moment to understand why recycling is the climate equivalent of bringing a knife to a gunfight. So first, as I mentioned, it can be material and energy intensive. Recycling metals is a reasonably high yield endeavor because it avoids the extraction and smelting of ores. But recycling glass only avoids 10 to 30% of the energy of de novo manufacturing, which is not to say we should throw out our glass, but rather to emphasize the importance of reusing it. Secondly, the recycling market is dynamic, and vendors will only collect recyclables if they know they have someone who will buy it. And that's why you hear stories of carefully segregated recyclables being thrown away, because there isn't always a buyer. Thirdly, there's a well-described phenomenon known as Jevons paradox, in which efficiency gains lead to increases in consumption. A recent paper documented a 6% increase in consumption with the introduction of a curbside recycling program in North Carolina. When people feel absolved of their environmental responsibilities by throwing something in a blue bin, they no longer pay any attention to conservation. Why not print all the articles for Journal Club when I can just recycle the paper? Now, I realize it's logical for people who are enthusiastic about this work to focus on recycling, but my goal today is to provide you with ways of having more impact, of recognizing opportunities within your scopes of practice to improve surgical sustainability. And I also want to caution you that this is an easy target for industry action, to talk about making recyclable packaging for their single-use products, when what we really need is purpose-built, reusable products made for durability and longevity. We published a policy paper in 2020 mapping out a circular economy strategy for the medical device industry. In addition to the circular economy strategies shown earlier, we highlighted the importance of upfront reduction. That is, questioning the need for material resource use before focusing on the environmentally preferable selection. And we looked at the forces driving our current linear economy through the perspective of a number of key stakeholders. So these include a perception of improved safety with single-use items, which is unsupported by data. It has prompted hospitals to adopt single-use dominant supply chains due to risk aversion, and it's resulted in regulators favoring single-use devices by making it easier for hospitals to be accredited if they're single-use dominated, and by making it easier for manufacturers to bring new single-use devices to market. For example, the FDA puts the onus and liability on manufacturers to develop safe reuse protocols for reusable devices, but they impose no stipulations around single-use labeling. As a result, manufacturers have an incentive to market everything as single-use, even if a device could be safely reused. There's also a perception of improved convenience, in that hospitals avoid the need for infrastructure, for inventory, and reprocessing. And while this may be true under business as usual conditions, it leaves them vulnerable to catastrophic disruption. And finally, current high-throughput business models rely on single-use consumption to maximize profits, so manufacturers employ all manner of strategies for planned obsolescence to drive uptake. What would a circular economy in surgery look like? Well, let's start with reduction. Studies of surgical instrument utilization across specialties show that we consistently use only 13 to 66% of the items opened for a case. And while obviously there is a need for some rarely used but critical instruments, these should not be 87% of the back table. A range of techniques for surgical instrument optimization have been published, from simple consensus-derived standardized pick lists to RFID tags and AI platforms, and all of those show that it's possible to safely reduce the number of instruments opened for a case by 26 to 63%. Now recall that reuse is the best circular economy strategy. Where choice exists, select the reusable option and encourage your hospitals to source as many reusables as possible. Where choice does not currently exist, we need to work with industry to innovate toward reuse, because that is truly the only sustainable option. We cannot maintain infinite consumption on a finite natural resource base. Circular product design includes principles like modularity, recognizing that there may be critical components of a product that must be replaced with each use, but these should be minimized and the bulk of the product designed for circularity and longevity. Here, the evolution of endoscopes is instructive. Beginning in 2013, a number of outbreaks of multi-drug-resistant organisms were linked to duodenoscopes. This was the result of contamination of the elevator channel despite proper cleaning procedures. Manufacturers innovated in response differently, with possible solutions ranging from disposable end caps to prevent ingress of bacteria into the elevator channel, to modular disposable elevator channels, to entirely single-use duodenoscopes. Unfortunately, the latter has captured a disproportionate market share, aided and abetted by the FDA, and single-use endoscopes are rapidly gaining traction across all specialties. This is massive over-engineering to address a problem that could be solved by having disposable components of an otherwise reusable product. And if you think back to our drivers of a linear economy, the reasons become clear. These are complex fiber optic devices. Manufacturing them for single use is akin to buying a new iPhone, sending a text, and throwing it out. I don't believe that endoscopes cannot be engineered for both durability and safety. The problem is that the incentives aren't there, and you all can help to change that. There is a robust evidence base demonstrating the environmental superiority of reusable over disposable products. Life cycle assessment is the gold standard of environmental impact assessment, in that it compares all of the material and energy inputs and outputs between products or processes across the entire life cycle, converting different products into comparable functional units so that we can reliably compare apples to oranges. Multiple life cycle assessments of surgical textiles have shown several-fold higher petrochemical use, emissions, and solid waste with disposables. Circularity in healthcare requires that we think across silos, like the notion of repurposing surgical gowns as non-sterile PPE when they're no longer fit for the high-level barrier protection required for surgery. Gore-Tex surgical gowns are FDA approved for 75 uses. After that, they can be used many more times as non-sterile PPE before they can then serve as fiber fill for insulation or upholstery. The environmental savings you see here with reusables only capture the approved 75 uses, so in actual fact, the benefits would be much higher if used within a true circular economy. A circular economy has also been shown to be more cost-effective, such as in this study comparing reusable to disposable laryngeal mask airways. Not only did they show that the reusable outperformed the disposable across every environmental impact category, but they also saved Yale New Haven Hospital $500,000 a year. Another benefit of a circular supply chain strategy is heightened resilience. The deaths of unprotected healthcare workers during the early waves of the pandemic due to PPE shortages were the result of hospitals being reliant on single-use PPE, and therefore unable to scale up their capacity to meet the surge in demand. Hospitals that were well equipped with Gore-Tex gowns and reusable respirators performed comparatively well. This type of disruption is not unique to a pandemic. When Hurricane Maria hit Puerto Rico, we experienced shortages in normal saline, propofol, and a variety of other drugs that are manufactured there. Supply chain disruptions are projected to increase, so the added benefit of supply chain resilience that is conferred by an emphasis on reusables really can't be overstated. Now, to show you how we can apply circular economy principles in a real-world setting, I want to present work done by my resident and graduate student, Dr. Karina Spoialo, looking at perioperative warming. We decided to study warming because it's a universal practice in surgery. It's subject to highly variable practice patterns, and there are multiple equivalent options. So in general, we can actively warm patients, which is most commonly done with forced air, or we can warm them passively with flannel blankets, which are not as effective as active warming. We compared 3 currently available active warming devices, including the forced air bear hugger, a carbon fiber resistive blanket, and a circulating water garment. We quantified the carbon and financial costs of a flannel blanket and estimated, based on our own usage, that we spend up to $400,000 a year and 48,000 kilograms of CO2 equivalents each year, which is akin to burning 54 tons of coal, on a largely ineffective warming strategy. When we compared the environmental performance of the active warming devices, we found that the resistive blanket vastly outperformed the others, with 80% lower overall environmental impacts than forced air or the circulating water garment. This should be unsurprising to you now that you know that reusables consistently outperform disposables, but it's nonetheless a striking result. We then looked at different combinations of warming devices and practices, from the pre to intra to post-operative settings, and found that the most sustainable scenario was one in which the resistive blanket was used throughout, and the least sustainable scenarios involved flannel blankets pre and post-op, which is precisely what we were doing at our own institution. Since we didn't have the resistive blanket, we decided to optimize the sustainability of our current practices by focusing on reduction of flannel blanket use and minimizing single-use disposables by preserving the Bear Hugger Flex gown throughout the patient's journey from pre to post-op, converting it to the appropriate warming blanket intraoperatively, and then back to a gown and PACU. We undertook an ambitious QI initiative, and we implemented expanded pre-warming criteria in keeping with international guidelines, such that most of our patients now receive a forced air warming gown preoperatively, and this gown is preserved through their procedure and allows them to be actively warmed in PACU. As a result, we've been able to reduce our flannel blanket use from a mean of 6 per patient to 3. Instead of getting a new upper or lower body warmer in the OR, the flex gowns are being used intraoperatively and preserved through to PACU. Our hypothermia rates have decreased, and our patients are happy. We are working on trialing some resistive blankets, but I wanted to show you this example so that you would know that even in the absence of a reusable option, you needn't just throw your hands in the air and determine there's nothing you can do. We can always question avoidable resource use and take a thoughtful approach, even when relegated to single-use consumables. Now, I want to finish by bringing to your attention an area in need of application of this same kind of circular economy lens. The uptake of robotic surgery is rapidly expanding globally, and its application to new procedures is continually described. In its current state, robotic surgery has considerably higher environmental impacts than analogous laparoscopic procedures. This recent systematic review reported up to 43% higher greenhouse gas emissions and 24% more solid waste generation by weight. One of the most rigorous and comprehensive life cycle assessments included in the review compared laparoscopic to robotic hysterectomies in the US and found that robotic hysterectomies generated over 800 kilograms of CO2 equivalents, which is equivalent to driving a car for more than 3,600 kilometers. The vast majority of these emissions in both laparoscopic and robotic cases arise from anesthesia and the production of disposable items, with only a tiny fraction attributable to waste disposal. In fact, the authors of that study actually looked at the emissions reduction potential of recycling in these cases and found that it was less than 2%. These data continue to reinforce the need for a reusables revolution. I reiterate my previous exhortation to not be distracted or falsely reassured by the promise of recycling, as it is of little impact relative to the production of the disposables used. Now, I'm not going to stand up here and tell you not to do robotic surgery, but much of our current surgical practice is unsustainable, and the consequences of persisting in these patterns are dire. If ever there was a time to channel our collective innovative capacity, it's now. You are incredibly powerful agents of change. I would ask you to be aware of the unique role we as surgeons play in our current environmental crises, to be responsible in your clinical practice, not thoughtlessly and universally over-investigating or practicing defensively, but testing and treating appropriately. and using the tools available to you, not simply because you can, but because they confer a reasonable benefit. The biggest single change we need is a shift to reusable devices, to encourage our hospitals to procure them as available, to use them preferentially, and to make them exist where they do not currently. Thank you for your partnership in this endeavor. I truly believe that we as a surgical community can achieve net zero emissions in our practice, and in so doing, make our impact on our patients and our communities net positive. Thank you.